Our last speaker is Ade Oyemade, and she's from the Scarborough Hospital, and she's the interprofessional educator at the Scarborough Hospital, and she's going to talk about incorporating HOBIC into the safety crosses. And I don't know what safety crosses are. Ade.
Hello, everyone. My name is Ade, and I'm the manager for interprofessional education, as well as the professional practice leader for nursing, and also the nursing resource team manager at Scarborough Hospital. And I'm going to be talking to you about sustaining change. As you all know that we're all going through so many changes, especially with the practice changes in this complex environment, and how can we be using data like the HOBIC assessment on safety crosses. So a little bit of the context of what I'll be talking about is the context of HOBIC measures and professional practice, because we've been doing HOBIC for a while, and what have we done and what are we doing differently with HOBIC measures. Also, we talk about the structure and the process aligned together, and also the corporate quality indicators, using that also to leverage HOBIC, and also safety quality results, the impact on patient outcomes and interprofessional practice itself. So just a little bit about Scarborough Hospital. For those who do not know Scarborough Hospital, it's a large community hospital, and we have two campuses. We have one at the Macaron and the General, and we have about probably 100 ED visits yearly. We have about 6,000 deliveries. We have a huge and the largest renal dialysis program. We have one of the CACTORAD, one of the largest volume. And we have very diverse community, and most of our population speaks Tamil and Chinese. And we have about 1,400 nursing staff, which RN population is about 70, but going down right now. And I think about RPM will be 30%. And we have about 3,400 nurses. So why HOBIC? Do I have to? And I'm sure all of you can attest to this, because we've started HOBIC since 2008, when I started off at the Scarborough Hospital as a nurse educator in surgery. And this was one of my mandates, to lead HOBIC at that time. And some folks, was only 2 units out of about 13 units, each med surg, that had only electronic documentation, and HOBIC had to be done on electronics, and then we had to do paper charting for the rest of everything else. So it really didn't make sense to staff nurses. You're making me do more work. This is more work for me. And with changes in leadership, we did not follow through in terms of what are you using this data for? What does this make sense? Okay, HOBIC is, yeah, so what is HOBIC? So in short, HOBIC was a bit labeled. So they felt stuck with HOBIC, and over the years, over 1 or 2 years, the data was going down, and we were not they were doing it, but they were missing a lot of data, because and there's a couple of reasons to that, because they would do it electronically, and then they will go on their paper and write the same thing. So we're doing a bit of duplication in terms of trying to do initial assessment. As you all know, I always tell nurses, my colleagues, and say, HOBIC is just good data. It's just good documentation. It is assessment. It is what we've done as a nurse for so long. So, but it was a tedious thing to try and get them to do it. And if they do it, and all you have to do is not do the audit for maybe 1 or 2 months, and then you see the data going down again. So it was a bit of struggle. What do I do? How do I do this? And you all know there's no dedicated resources for HOBIC. It's something you're doing with what else, everything you're doing. So do I have to? So this is where we go. So some approach to move forward, and being the centerpiece, working with Rhonda Steedman-Carlson and in the professional practice, everything has to come through us, and we always work with every program. I decided, and Rhonda, is that we started off with electronic documentation for all over the organization. So that was a great opportunity to build to start all over again and not call it HOBIC, not call it anything, just integrate HOBIC measures into it, but making sure that when you're doing your documentation, it doesn't matter if you say within normal limit for your respiratory assessment, it drops right to difficulty in breathing, which is dyspnea, so you would have to say yes or no to that. And also helping that to happen, we integrated it to every med-surg electronic documentation. We took away a lot of duplications in the paper. We looked at what paper discharge assessment we had. We were only doing checklists for our nurses, so we decided to integrate HOBIC discharge and admission into that. So everyone doing the discharge will be doing HOBIC because we can actually measure that and look at that. So that was done. And I told them, just don't use HOBIC, just integrate it and put a star on it. So when we pull in the data, we will know what we're pulling. So that was helpful to move that forward with. And also, we never implemented HOBIC in the cardiac, of a two-step down cardiac, and we did that now. So also for the policies, we looked at the policies. We're asking nurses to, for instance, with falls and pressure ulcers, we were making sure that our policies and the tools we are using did identify. For instance, HOBIC was in the last 90 days and the last 60 days. So we were making sure that we were asking the same question in what the tools we're using, and also does the policy align to what we're asking nurses to do? Because when we looked at it, there was different bits of things that they had to do, and it was becoming an issue with workload, with the complexity of the environment we had. So we looked at that. There was a huge focus now on patient outcomes, and we needed to measure what we were doing and how we were doing it well. So one of the foci, which I will talk about, we were also using our corporate indicators and benchmarking with other organizations to see how we were doing, and that was being shared across the organization. And we had a new focus in terms of professional practice, trusting our nurses to let them understand they're self-regulated, that we do trust what you do, that we entry into practice competencies would not be something that we were going to be hand-holding, but you would have to take ownership for that. Because that was helpful also in terms of completing your assessment, knowing what you're supposed to be putting in your assessment was something that was entered to practice, and it's not something that I could support you, I provide you resources, but I was not going to pay you for that. And there was a full scope of practice, working to your full scope of practice, and also a huge part was interprofessional collaboration among all other professions. So it's not about nursing-centered outcome. Yes, it is about nursing, but also physio, OT, social work. We're able to support that piece around management strategies for falls, and also getting dietitians and everyone involved around pressure ulcers. And so the organization also embarked on a journey around data care, business performance improvement. So all those together was able to help us. And in anything we do, I always went back to HOBIC. So I was the HOBIC queen. I would go back and say, okay, so HOBIC says, okay, 90 days. Can we incorporate that? What does the evidence says about that? And this is, oh, that makes sense. So I was making sure it was integrated in every area of the way, because that is the only way it would make sense for a staff nurse. That was the only way, because we're now speaking all the same language. And so then we moved all forward. So how did we use HOBIC? And we are getting the data. The data is getting better. We can do more work with the data, and I'm glad I came to this presentation. I almost missed it just by yesterday. I was jury. I went on Monday, and I was selected as a jury. I'm like, oh no, not a jury duty at this time. But able to pull things together yesterday. I was able to leave the courtroom at 6 o'clock. So I emailed Peggy right away, I will make it. It's definitely I'll be able to make it. Because I really wanted to know what other organizations were doing, what we could do differently in terms of our data, and how we could use this data to maximize what we're doing, and also to leverage what we're doing in the organization. Because I think it's important that HOBIC cannot stand alone on its own. It's not really what should stand alone. It should be integrated to everything we're doing across the organization, from bottom up or bottom down. So then we looked at the organizations were keen on a couple of things. They were keen on falls. Everybody wanted to measure falls. It was something that was length of stay was driving cost, and it was also a patient safety issue. And also HOBIC had great questions with false. So that was good. And then the pressure ulcers was just you have a pressure ulcers code 1, 2. So that was fair. Jackie, one of our clinical nurse specialists, said that is perfect. If you code this, then you go right into something else. So what we did was the electronic documentation. If you say yes to those questions in HOBIC, then it automatically give you a high risk, that this is a high risk patient, and then you will be able to go right away in your stuff to make sure you fill that false form. Now, the false form was not a tedious one. We decided to use the Shimmy tool, which was so easy. 2-3 questions, you know exactly if this patient is high risk or not. And if that is the case, then you go right into interventions and what are you going to do about these interventions. And so that was helpful. So if you say pressure ulcers, so it all starts from HOBIC, the assessment. If you code that and then you go right into your braiding and do what you have to do, and then you follow through with your management strategies. And so pain was a big thing, and I heard a lot about pain today, and you folks have heard a lot about pain too. We couldn't measure pain, so what we did was we look at pain tools. What are the tools we have in place for pain? Is it across organization? Many people we were shocked that we were having 3 different types of tools that we were using to measure pain. So we're able to streamline it to one for adults and also streamline it for pediatrics. So that was helpful to do that. And being that every electronic documentation had to go through me before it was signed off, I was able to look at what they were asking for. So for instance, HOBIC questions were not for pediatrics, but for adults, we were asking the same question. And also that was helpful for the nurses to know this is not about HOBIC, but this is about patient safety and also good assessment. So the assessment I put there plus was a key thing for us because we needed to do that. And if we don't have the HOBIC assessment completed, we really cannot move forward. You couldn't be able to manage your patient very well. And the key thing about it is that they would know, because now if the patient falls, which I'll talk about. And the management strategies was not about nursing alone. We needed to get away from nursing because nursing cannot do it alone. And so we were starting to engage physiotherapy. We talked to them about, I spoke to them about HOBIC, their allied health, around what HOBIC does. So now HOBIC data is there. Everybody has electronic documentation. It's not only nursing, it's nursing and allied health. They're able to view those data and look at what the nurses coded in terms of that. And that will also be helpful to manage falls. And in our falls policy, we did not put nothing to do this, nothing to do that. In terms of managing the strategies after the patient has been identified by a nurse, because they would do the admission piece. Then the interprofessional team would take on and make sure the patient is being managed appropriately. And so we also decided to, we're not moving forward, and we will be measuring these indicators daily and quarterly. And so that's when the safety crosses came in. And also, how do we benchmark this across the organization? For the quality church, we did safety crosses across. The 3 key ones that we chose for our safety crosses was this same one I told you about, was falls and pressure ulcers. Not necessarily pain, because surgery made it very clear everybody's in pain and we're managing it. And with our NCRP, we were doing well with pain across the organization. It's just managing the tools and making sure we have a great tool for our patient. Not necessarily, but have one tool that is consistent. But we were able to use safety crosses to manage, to actually daily look at what's going on with our falls and our pressure ulcers. And also we were using a purple sticker. We all had a whiteboard across the organization. That's one of the things that was done with improvement, the data care. So in that, you would see a purple for falls and an orange for pressure ulcers. Anybody that had those purple or falls will be discussed at 11 o'clock It's called huddle time, and all interprofessional staff will be standing right there. And also, they would also be discussing at that time safety crosses, which I would focus on. So that was something that was discussed daily. And what are you doing about it? It's not about, okay, we have it. What are we all doing about it? Come up with a strategy. So, and it has to be something that somebody's going to take ownership for, whoever is going to do it, based on their expertise, not only nursing, but based on the expertise of every other profession. What are we doing about it, and how do we manage this to get better? And also, we also used a scorecard. Those 3 safety indicators I talked about was on everybody's scorecard, and it was measured. It was either you're red or green or yellow, and what are you doing about it if you're either one? And also, we had something called the safe reporting, in which every one of you would have incident reports. So if somebody has an acquired pressure ulcers on 2nd stage, that is incident report right away, and that goes right to the manager, right to the clinical nurse specialist, and also the director, that you have an acquired pressure ulcer on your unit. If you have falls, that goes into the data, and that goes already there. So that is collected every 3 months and shared across the organization. So our safety crosses, and I just give an example of what it looks like, and I'm sure most of you have that in your organization. That's exactly what we're using right now for our falls and for our pressure ulcers. This has been very helpful for nurses, and for not only nurses but allied health. Coming on the unit and they know something happened last night, or something happened last evening, or something just happened. It's very clear. It's a red. Something happened. What's going on? Is that my patient? So that's the discussion. When they get into the huddle, it's like, what are the safety risks? What are the safety concerns? What are we doing about it? And how do we manage this patient differently? And that is a key focus for us, because we did a lot of data. We did a lot of input. We did a lot of auditing, and what else? And the nurse is like, what else do you want me to do? I try my best to do as much as possible with this admission, but now bringing it back to them to say, you know what, you did your, because then if somebody has a fall, not only would we say, oh, that person had a fall, we will go back to know what that patient assessment was done. Did we have was this patient allotted as a high-risk person? Patient, and moving forward, if this was not done, then there was no way we could have identified this patient at high risk. So they all realized quickly that it is important that you need to do your false assessment. It is not about leaving it for the next person. Yes, sometimes we need to do that, but how can we quickly assess our patient based on the fact that you're only asking 2 questions, not the huge form, but you're asking only 2 questions to identify this. So this is how we have been working at Scarborough Hospital. We do have a lot of improvement in terms of moving forward with the rest of the HOBIC, but this is where we are in terms of what we do with our HOBIC, using those 3 indicators I mentioned. So overall, they've been doing this for about a year now. We've seen quite a bit of improvement in terms of patient outcome, and only measuring those 3 things. Pain has always been our strength in terms of doing that, but the acquired pressure ulcers, we've seen a decrease not only in our prevalence but also in our daily. Jackie has shared that with our team, a senior team, that they're seeing a difference. I have been in the court for like 1 week now, so I don't have my data, but if anybody needs it, I can share it with them. But there has been a decrease in what we have done, and the falls has significantly actually decreased in some areas that were known to be problematic, and they are working a lot. They have understood that they don't need to, sometimes you cannot prevent fall, but we can prevent injury, and helping nurses understand, such as don't put Siderel when that you know that patient is going to get up. There's been a lot of education in terms of moving forward with that. And also, it's been a lot of increased accountability among frontline staff. You know, I really have to do that first, because if this patient falls and it's red, you know, they're going to go back and look at what's going on. So I really need to make sure I do my falls assessment, and that has been key. And also interprofessional staff saying, okay, I've identified this patient as a fall. I am going to do more work with this patient as a physiotherapist to do it better, because that's the expertise around that area. And also the unit leaders, which is the managers, And the clinical resource leaders prioritize and push, they are all pushing continuous daily improvement. They're all having the discussion around falls and pressure ulcers. So if there's a purple on a patient that was not there before, what are we doing? How are we managing this patient? It's all discussed in huddle. And also, this has really improved interprofessional collaboration among the staff, among the physio OT. It's really helped them in terms of interprofessional education. So it's not about what does the physio do, oh, they only ambulate. They do know that they have expertise in certain areas and they should be consulted. And they will be having that discussion, and you will see the physiotherapist that, you know what, I think I can handle that, I know what that patient needs, and they take on that care. So that's what we have done so far at the Scarborough Hospital. We are going to be still using some of the data that we saw today and how we can improve better using our HOBIC data, but that's it for now.
I felt your pain when, to quote Clinton, I felt your pain when the early days of HOBIC. And we struggled with this because you were not alone as being the only hospital that had HOBIC online, but the rest of the nursing assessment was the same old, a lot of narrative on paper. And to get nurses to move between those two media, frankly, the paper and the online, was a real challenge. And I think other places that then moved to the whole thing being online and able to integrate HOBIC into the whole nursing assessment. And then the assessments changed. Yes. They became more succinct. We weren't asking, they weren't 8 and 12 pages of narrative.
We were able to streamline it, and it wasn't looking at a workload. So able to complete it would be the next step to make sure it's been completed properly.
Yeah. Okay. Well, I'm glad to know that I now know what a safety cross is. I didn't know what that was before. I thought it was something you put on your car, We
have the color there, green, and everybody goes, yay, green today. Yeah.
Okay, any other, no question, but any questions for Ade or comments?
I'd just like to say how impressed I am that you've worked really well with the nursing staff and to look at issues relating to double documentation, because there has to be some carrot for the staff in order to do this, and if the more useful nurses find this in their practice, the more likely it is you're going to have good data. And some of the research that Liz and I have been doing over the last decade with others shows that the more useful it is, the better, the more likely it is that providers are going to collect the data. And when I hear some of the stories about that the Kathy's brought forward of having things in the Cardex and the care plan and how it's actually informing care, I'm really encouraged that other institutions might adopt HOBIC. And I'm wondering, Dot, maybe more for you and Walter, have you considered having some of the organizations that we've heard from today speak to some of the institutions who are not HOBIC participators?
Ruth Lee, Chief of Nursing Practice at Hamilton Health Sciences. When I look at the title of your presentation, I would say this is one lady I must ask questions and talk to. Because we just started the huddles and the safety crosses and all that. And when I see, wow, that's how we can use HOBIC data, that's fantastic. So please tell me at the ground level, how do you do it at your units, for example, safety crosses?
So we have safety crosses, which is 31 days, calendar year, and it's there. So if there's a fall, the nurse would go in and put a red, meaning there was a fall. So at 11 o'clock, everybody would stop and gather around the whiteboard, the huddle board, where there's all the patients' names out there. And after they have put the red crosses, which the red, they will go ahead and put a purple magnet sticker on that patient's name, meaning that that's a high-risk patient. So the manager and the charge nurse usually would have a discussion before the huddle. They use something called the stat sheet, which is one of the, what they use at the BPS. The stat sheet talks about safety issues on the unit. And so the manager is already aware that this is an issue on the unit. And then they would have a discussion to say, okay, we have a fall. How could we manage this patient better? Has this patient fallen before? Then that's when they would have the chat. So you must have actually done your assessment for you to be able to know. So that patient would have an assessment, and I can tell you right now, our falls assessment has really gone up in terms of completing. The completion is really great. Before, we have to have maybe 20, 30%, 40%, sometimes it's about 100% in some areas right now. Because they would look at it and go, okay, so this patient fell. What are the issues? We have pharmacy, we have physio, we have OT. And those three key people are there. We might not have other professions because there's only a little bit of them. And have that broad discussion on how we can manage this patient using multiple strategies.
So you kind of bring in your HOBIC data?
The
right
HOBIC
into
data
the
is our initial assessment.
Okay.
It's what we use to assess patients. And so we would also make sure that we go back and reassess that patient using the same questions. But we also have a falls assessment tool that we will use. If you're high risk, we will use that tool to make sure, because with that tool, if you're high risk, then it tells you exactly what strategies you should have in place for that patient. So it's about using HOBIC as your initial assessment, and also we can also use that discharge, but we're not there yet. But actually using it in practice, letting them understand that they're collecting this data, we are using it, and they can also see it in practice was a key thing for us to buy nurses back in.
Great, so we'll exchange notes.
Yes.
Thank you.